Thoracic Surgery and Incentive Spirometry. These are our two research articles looking at incentive spirometry. Here are the contents of our presentation. Post-thoracic surgery patients are the target group for both studies. Thoracotomy and lung resection patients are considered to be at high risk for developing post-operative pulmonary complications. Agostini included a high-risk subgroup based on these factors over here. These are our priorities of the target group problems. The problems we have identified are associated with the following post-operative pulmonary complications, including nosocomial pneumonia, atelectasis, acute respiratory failure, pneumothorax, and etc. Lung volumes is our first priority problem, as increasing lung volumes will essentially have a flow-on effect to the problems of gas exchange and impaired airway clearance. The causes of reduced lung volumes are atelectasis, loss of lung tissue, compression of lung tissue, and pain. Atelectasis is a consequence of thoracic surgery due to general anesthesia disrupting the respiratory drive, leading to diaphragm dysfunction. This, in addition to supine position, leads to reduced lung volumes. Loss of lung tissue and lung resections causes a decrease in surface area available for gas exchange, hence lower lung volumes. Compression of lung tissue and pain also contribute to reduced low lung volumes due to the depressive effects of general anesthesia and analgesics. The next priority is impaired gas exchange, as improving it may lead to earlier weaning of mechanical ventilation. This decreases the risk of infection as a natural upper respiratory defense mechanism is restored. Impaired gas exchange can be caused by hypoxemia and/or hypercapnia. Reduced lung volumes leads to an altered diffusion concentration and reduced lung compliance, resulting in VQ mismatch. The inability to clear carbon dioxide due to shallow breathing post-operatively may lead to hypercapnia. The next problem is impaired airway clearance, which is caused by altered composition of mucus, impaired mucociliary clearance, and abnormal or ineffective coughs post-surgery. These factors are influenced by systemic dehydration, medications associated with surgery, and affected cough mechanisms respectively.
An incentive spirometer is a device that provides visual feedback when a patient inspires at a set flow rate or volume displacement level. The patient creates a seal around the mouthpiece with their lips and inhales in a controlled manner with the aim to raise the ball in flow determined or piston in volume determined to a predetermined height, holding the target in place for the duration of their inspiration. Here the patient holds the inspiration for a couple of seconds, if possible, before exhaling as normal. In the Agostini study, the patients were instructed to take a deep breath through the Coach 2 incentive spirometer, followed by an inspiratory hold and passive expiration, performed 10 times hourly. Treatment was escalated as required. Treatments also involved the standard post-op procedures of coughing, early mobilization, and shoulders exercises. In the Gosling study, a slow maximal inspiratory maneuver was performed through the volume feedback incentive spirometer, followed by forced expirations and coughing. This was performed 2 sets of 5 to 10 repetitions hourly. The target volume on the device was increased daily, and postural drainage and suctioning were performed when necessary. The primary aim of incentive spirometry post-thoracic surgery is to prevent or improve cases of atelectasis by increasing the total lung volume and tidal volume. This is done by increasing lung expansion through long and strong sustained inspiration with an inspiratory hold. The incentive spirometer provides visual feedback, allowing the patient a clear and measurable target to aim for when doing their thoracic expansion exercises. These deeper breaths with inspiratory holds cause increased parenchymal stretch, opening any atelectatic or near atelectatic airways, increasing the tidal volume and the total lung volume, including FRC, which is an essential component in splinting the airways open and decreasing risk of reaching the closing capacity. Volume displacement devices, such as those used in both of the studies provided, have been seen to encourage deeper breathing by increased recruitment of the diaphragm, resulting in decreased work of breathing, where the flow-dependent incentive spirometers have been found to increase accessory muscle use and increase work of breathing. In this image, the areas marked in green are the lung volumes most impacted by incentive spirometry. It is important to note that the increases in total lung volume will result in an increase in functional residual capacity, which will aid in the reduction of atelectasis.
Priority number 1 has been identified as reduced lung volume. Incentive Spirometry seeks to improve the patient's functional residual capacity and residual volume to avoid reaching closing capacity. Incentive Spirometry encourages the patient to take slow, deep breaths to provide more time for their air to travel towards the alveoli. During the inspiratory hold, the inspired air will aid in splinting the airways open to allow more air to travel into the collapsed alveoli via the collateral channels and reduce the risk of atelectasis. Impaired gas exchange can occur due to decreases to total lung volumes. Disruption to the gas exchange process can also affect the ventilation and perfusion ratio. For optimal VQ ratio, one of the contributing factors is available surface area for gas exchange. Improvements to total lung volume will increase the amount of surface area available for gas exchange and improve the VQ ratio. Mucociliary clearance and the ability to generate an effective cough are required for normal airway clearance. Reduced lung volumes will lead to a decreased ability to generate a forceful cough and lead to impaired airway clearance. If a cough is weak and ineffective, there will be greater difficulty in creating sufficient force to clear mucus plugs. Improvements to total lung volume will also cause increases in effective airway clearance and the ability to generate a more forceful cough. The main aim of incentive spirometry is to increase total lung volumes. This addresses patient problems of impaired gas exchange by increasing the volume of gases available for perfusion and increasing surface area where perfusion occurs. Increased gas exchange and increased lung volumes addresses the problem of impaired airway clearance by increasing paracardial stretch and the recoil in the cough mechanics. According to the Pedro scale, both of the studies received a 6 out of 10. Both studies did not have concealed allocation, subject blinding, therapist blinding, and neither had an intention to treat analysis. It should be noted that blinding of therapist and patient is not possible due to the nature of incentive spirometry as a treatment. Consequently, these two negatives are not true faults in study design.
Randomized controlled trials are the gold standard in study methods, and both studies were RCTs. The research aims were clear for both, with Agostini comparing the effects of incentive spirometry to deep breathing and Gosling comparing incentive spirometry with normal post-op chest physiotherapy. Both research designs had clearly outlined control and intervention groups that were similar at baseline with clear treatment and dosage. Neither study went into detail about recruitment methods. Gosling recruited patients who were able to use incentive spirometry and follow preoperative instructions. The study implied that participants were patients scheduled for lung or esophageal resection. Agostini required that patients be over the age of 18 and were scheduled for thoracotomy or lung resection. Neither study tracked compliance to ensure that participants followed exercise plans. Both studies followed patients until discharge from hospital. We feel this was an adequate follow-up considering that the aim of the study was to assess post-op pulmonary complications and the length of hospital stay. Agostini stated that they were approved by an ethics committee where Gosling didn't mention ethical approval. Outcome measures were clearly identified and defined.
Based on the two papers, incentive spirometry was not found to be any more effective when compared to deep breathing exercises or chest physiotherapy. However, Agostini found an increase in outcomes in favour of the intervention in the high-risk subgroup. However, it was not statistically significant with a p-value over 0.05. Therefore, this is not applicable to clinical practice. As we have discussed, the research quality is not of the highest quality. Therefore, careful consideration is required when providing incentive spirometry as a form of treatment. However, neither of the studies reported adverse events as a result of incentive spirometry as a form of treatment when compared to deep breathing exercises and chest physiotherapy post-thoracic surgery. Based on current evidence, there are no additional benefits to using incentive spirometry as a standard post-operative procedure in thoracic surgery patients. However, visual feedback may be beneficial for some patients to provide motivation in performing deep breathing exercises. Our final conclusion is higher quality research evidence is required to evaluate the efficacy of incentive spirometry. Here are our references. Thank you.